Interesting, I think for that guy got some maternal leave. His wife is giving baby, but he gets the 男的老是得了产假。也可以上，去这个为啥是你自己的？He forgot. This was the last month. If he applied earlier, he can get 6 months or so in the year. Paid leave. When he learned this, it's already past the time.
Oh,
he can only enjoy 1 month.
1 month. You wouldn't claim the time. 6 months.
So you will start recording?
Yeah, it is recording right now. Hello, everyone. Thank you for joining the new series of OMNI-RÉUNIS Super Spreader Seminar. This is the first seminar in the year 2025. And first of all, as always, we have land acknowledgement. We acknowledge the land the OMNI-RÉUNIS Center's head office is located on York University. We recognize that many indigenous nations have long-standing relationship with the territories upon which York University campuses are located that fostered the establishment of York University. York University acknowledges its presence on the traditional territory of many indigenous nations. The area known as the Toronto has been taken care of by Anishinaabe Nation, the Mudansi Confluency, and Huron-Wendat. It's now home to many First Nation, Inuit, and Métis communities. We acknowledge the current territory holders, the Mississaugas of British First Nation. This territory is subject of the dish with one strong Manhood-built Congress, an agreement to peacefully share and care for the Great Lake regions. And we will have the Super Spreader seminars. We are here to collaborate with each other and share the research and make the most out of our research works. And yes, we will have the speaker, and I would ask Professor Zhu, the main director, to introduce the speaker again.
Okay, thank you for starting. Welcome back to the Super Spread seminar series. So this is the first one of 2025. So this year we can have 6 to 10 speakers of the whole year. So for the first speaker, we are very glad and happy to have Dr. Gelan Ayana
Yes.
to present his work. So Dr. Gelan Ayana is, a long introduction, so I will briefly tell you who he is. So he is currently the provost postdoc at the University of Toronto at the AIMM lab led by Professor Jude Kong, who was our CDM member, who was at York. Unfortunately, he left us, but we are still young. In fact, he has the details I will not read, but his research interest is about AI for health and health informatics. It is modeling and surveillance, public health data governance and policy, global and digital health. In fact, he has more achievement than what is listed here. Most importantly, there is a Bill Gates Foundation claimed this is a rising star scientist. So this is an excellent title. Also, he's an outstanding academic. He received outstanding academic achievement award from the Korean Ministry of Education. The one is American Association of Cancer Research, Sanofi Scholar in Training Award. a lot of awards. He also, received a lot of funding from multiple organizations. But most importantly, I'm glad to welcome him to join also, even though he's at UFT, welcome him to join CPM, join us. In fact, as I mentioned, there are more detailed introduction about him. So I welcome you to look details to learn more. So the presentation, next page. Yeah, the title will be community-based approach to One Health. So very important and timely topic. So I will leave the time to Dr. Ayana. So let's welcome.
I think I have to change it to thank you for the generous introduction. It's too much for me. Not that, as they said, I'm just trying to solve some of our community's problems using artificial intelligence and most importantly, computer vision image analysis. Because I think this area is overlooked and not many people are working on that. So today I will talk about this, and coincidentally, today is World's Neglected Tropical Disease Day. Neglected tropical disease day. So I'm glad that I am giving this talk on the day that we need to talk about, because the diseases that we say they are neglected, they are coming back and also impacting many populations. So, for example, I will talk today about polio. Polio, like every country except Afghanistan and Pakistan, are given a certificate that they are polio-free. But last year, we observed during the Gaza problem, polio was found. And, WHO has to do many things to control that. So we have to, it's timely, and we need to be more focused. So thank you for inviting me, Professor Zhu and the OMNI team for this talk, even though it is just a month for me in Canada. This will be my first open talk. I will talk about community-based approach to One Health. I really like to see my research go into community, because that is very like the thing that gives me sense out of my research. You can do many fancy things, but if the community, your mother, your father, your grandmother, if they don't use it, especially for a person like me who came from Ethiopia, poor country, may no infrastructure, and if I can contribute to that, that would be the great one. So my talk will revolve around that. So today I will talk about how AI can be applied to community-based One Health, community-based zoonotic disease surveillance. That would be my focus. So contents of my talk, I will break it into 5 simple parts. The first section will be, I will talk about what's community disease surveillance, and then I will give you the process and the details of existing community-based disease surveillance by taking AFP or polio surveillance that we are doing in Ethiopia, and then how deep learning model can be applied to do community-based disease surveillance, like by taking acute flaccid paralysis as an example. And then this year, we received a funding from IDRC, International Development Research Center, the Canadian one, and FCDO, the UK's Foreign Commonwealth Development Organization, to work on this, to apply what we have been doing in polio and AFB to zoonosis disease, not only the polio and other infectious disease, we can also apply the same approach to zoonotic disease. So I will give you a framework that we follow, and also it's open for discussion. Professor was telling me we have to write some idea, work on some idea that is under the umbrella of One Health. So I will discuss that framework that we are working on, and then I will show you the prospect, like how far can it go. That's what I want to show you. So without further to say, let's delve into my presentation. Ouch. So community-based disease surveillance. So disease surveillance is about collecting, analyzing, and interpreting disease information so that mitigation and action can be taken in order to stop the disease. So traditionally, how disease surveillance is done is using the health system. For example, someone is sick, right? They go to the health facility around them, and then they will get maybe mpox. All right. So the health professional who is there will take that case and report it to maybe the National Public Health Authority or Ministry of Health or WHO. And that is how they do surveillance. Or there will be someone who is assigned for that district. Let's say in Toronto, there will be someone that's assigned, and he will observe by taking samples like frequently, once a month. And that's how they do disease surveillance. But it is the community that has first-hand information about diseases. For example, let's say someone broke his leg, like at home, right? You will hear if you are relative, people living nearby, or if you have some way of interaction with that person, you will be the first one, if he doesn't go. That is the case, for example, in Ethiopia. Many people, they go to health facility when they are about to die, right? So you don't get those information as much as you want from the health facility. So the most important thing is using the community. So that is what community-based surveillance is based on. Community-based surveillance is a system that involves community members reporting public health events to authorities, right? So it can help to detect disease early and also monitor public health emergencies and improve disease control. So it is performed, like I'm talking about that side of my slide. I don't know why this one is covering it. Community nominates influential people. That's how you. For example, there will be people who have a good name within the community, who have good relationship with the community, and then they will be selected. And then they will be given some sort of selection criteria. They will be given some, like tribe. In Ethiopia, we have different tribes, you know. I'm giving example of Ethiopia most of the time when I talk. Literacy, gender, and those stuff. Considering those, we select community volunteers, and then we train them. We train them to recognize acute flaccid paralysis. We train them to recognize mpox. We train them to recognize other diseases like HIV or other diseases, cholera. And then they will be given some tools that they use to report those diseases. And they will be networked to the normal functioning health system. That's how we start. So the process is detection, where warning is given, and then we will do triaging, right? Like it should be investigated, and then verified risk assessment, and then we will give response based on that. For example, if one child is suspected of polio in one area, you know, like in 1 week, it can affect 100,000 people. That's how like infectious it is. So there should be immediate response to over control those stuff. So what are some of the diseases that are reported using community-based systems? So for Ethiopian example, I'm giving Ethiopian example here, we are doing animal disease, human disease, and also integrated. Some diseases are like from animals to people and from people to animals. We call them like zoonotic disease. So these are some of the diseases that we do community surveillance on. So yeah, a little bit of, you know, giving you a background or stage of my talk. So let me take an example of AFP that we are working on and show you how we are doing community-based surveillance. So acute flaccid paralysis is any sort of paralysis within children under the age of 50. You know, AFP or acute flaccid paralysis can be Guillain-Barré or can be polio or can be other diseases which is related to other like nervous system or spinal cord system. But we need to identify which is which, right? Because if it is polio, we have to take action as fast as possible because it will infect many people. So poliovirus spreads really fast through fecal oral routes, and the state of transmission is oral transmission from feces to when the virus enters the mouth. So that's why, like, you know, when you share water, you know, like we use one river, like everyone interacts with that river. So if there is one spot, that the whole population will be affected. And that's how they found the case of polio also in Gaza. And it goes to lymph nodes and the intestines, and then travels to central nervous system, and then you develop an antibody. That's the transmission method. But what are the activities in acute flaccid paralysis? So this is a person, you know, like a focal person, the WHO focal person doing acute flaccid paralysis surveillance. You know, some community reports that we have some case that looks like polio or acute flaccid paralysis, and then they go to like a place where they were informed, and they are taking a look at the cases. So the first activity is detection. We do home visits, sample collection, you know, like stool samples should be collected if we detect polio, and clinical examination is done. And we need to do documentation, every details about the case. We have to report it, and then we need to do time reporting. Time is very important. That is one of the biggest challenge. Bill and Melinda Gates Foundation, now it is Bill Gates Foundation, the name has been changed. They spend like $50 billion to increase the sensitivity of poliovirus detection. Still, they didn't achieve much. That's the report last year. So time is very important. Time is very important. And collaboration, you know, you have to collaborate with community and disease surveillance officers and others. And then you need to also transport sample, because not every lab, for example, in Ethiopia, there is only one national lab that does this cases of poliovirus, because it is, I think it is hard, and they also lack some equipment. So this is a process of surveillance. In order, when we say surveillance, we need to have some indicators, whether to say we are doing good surveillance or bad surveillance, right? So some of the indicators are report completeness. 80% of the reports should be complete. For example, I have been looking into like 10 years of Ethiopian data on acute flaccid paralysis. The data is full of incomplete columns, right? They have the data on paper, you know, like they put it on shelf and something like that, but they don't have data, complete data that will help us to learn from, make a decision, and get out enough information about the disease out of the data available. And follow-up completion, because someone has been suspected for polio after 60 days, they should follow up. That should be done for 60 days. They lose that follow-up. Laboratory performance. Laboratory should identify correctly the cases and inform the population about the cases. And non-polio AFP rate. So non-polio acute flaccid paralysis rate should be higher than 2 per 100,000 population, and other stuff are considered in order to say we have effective and sensitive surveillance system. However, this surveillance of polio can be categorized. The first is acute flaccid paralysis. The second one is environmental. So this is, I was giving you the case about Gaza situation. They found the case, not from the people. You know, no one reported it, but they found it within the water, the pond. So in environmental surveillance, what they do is they frequently go to the ponds around the population. They take some sample, bring it to lab, like check for the presence of polio virus, and that is how they found the case of polio. Even during the war, they were able to control because it was not many people were affected, and WHO did amazing job in that. And then the second one is acute flaccid paralysis, where we have community and health facility based surveillance of people with those sort of paralysis. So this is like the types of paralysis. And when we establish community-based surveillance, how do we establish community-based surveillance? It has a process. So, like, why am I losing? Anyway, maybe it's like battery. Yeah. Yes. So establishing a community-based surveillance system has a process. So the first one is sensitization. We need to sensitize the community. We need to tell the community that we need to do this together. Like if the community doesn't accept, for example, for a long time, polio vaccine, people didn't accept it, You have to do sensitization in order to do also community-based surveillance because people won't tell you when they are sick if you didn't do the sensitization. So you do sensitization and you select community volunteers. So you select community volunteers depending on the criteria that I told you earlier. And then you support them. You support the community volunteers by training them, by giving them tools, and by teaching them of how to identify and report the cases. And then you build the capacity, and the activities include, they do active searching, they do record status, and they do reporting, all right? And then we need to also support that because some new diseases come. For example, I am doing this survey on mpox readiness for Ethiopia. I asked people who are concerned public. We have Ethiopian Public Health Institute. Many of the emergency officials, they don't know what mpox case looks like if they get it. Do you believe that? So they need training. They need to be like introduced to new diseases and update, refresh their knowledge. So that's why we need to give them supportive supervision and feedback. That's how we establish the system. And data flow, this is very important. So where does data start to collect about the disease and where does it end? That is very important process. So it starts within the community by mobilizing the community, and it ends at the national level, Ministry of Health and WHO. So during this process, the community volunteers do home visit, right? In Ethiopia, we have a culture. I don't know, in Canada, it should be tea drinking, right? I don't know the culture. In Ethiopia, people call each other, visit each other, and drink coffee. Once a day, because we have all the time, we don't work. So people meet in those scenarios. So when they meet, these community volunteers get the opportunity to interact with the community and see if there is someone sick, if there is a case, and they report it out. And ensure that people get oral poliovirus vaccination and surveillance coverage and data collection and assess the impact. And here the community is a key player. And then they report to community health workers and health development army. We have those structures in Ethiopian system. And then they go to local government authority or district officers, surveillance officers. And then that goes to state level or WHO and surveillance officer and other. At the end of the day, there should be laboratory between the health facility and the national health system. That is how the data flow. Reporting flows down and feedback flows up. So from WHO and the country Ministry of Health, it goes down to the population to mitigate, to take action. And there have been some technological development that have been used. Here is my interest area. So in order to expedite the process of surveillance of this disease, we had something called ABADR, which has been implemented in many African and Asian countries, and e-serve checklist, kind of online checklist, and then ODK. I think most of you know, if you are working on public health, ODK is the only open access data kit that people use in order to do surveillance and disease information. And ISS, this is also a real-time reporting, but it is high level. And also Essence, those devices, they come into like web app and mobile apps. These technologies really improved how disease surveillance is done. But when we come to the specifics and breaking them down, we got some challenge. So as a whole, as an overview, engaging local population in disease surveillance is very, very important and crucial because it provides quick response and effective management of outbreaks. However, there are challenges. For example, in Ethiopia, 2 incidents. We have been looking at Ethiopian surveillance data. When COVID hit, other disease surveillance, it was 0. Even though there is a disease, no one reported to the national level because every resource, every people, it went to COVID. All right. 2, there was war, for example, really hard war for 2 years, covering half of the country. There was no surveillance report. So security is a big concern in those areas, and low community awareness and geographical inaccessibility. Most of the geography in rural areas are not accessible. Emergence of new pandemics, those are the challenges. And however, we need to consider some improvement that were brought about when we use these technologies and also other activities, even introducing community-based surveillance. Some of the improvements are the country deployed some mobile clinics, community awareness has been improved, and also the usage of digital tools has been increased. However, people suggest when you ask them these 3 things, deploy more digital tools, which have the capability to tell them information, for decision making, not giving the information, because many people don't know what to do with those information, right? You need to give them with options to make a decision. Especially this is for higher health officials. And then collaborate with community widely and by being creative and using different tools is very important, and working with stakeholders. So this is all about the community-based surveillance system, but I will give you one of the things that we did. So what we did is, in order to improve this problem, we developed an automated system to develop deep learning-based community-based surveillance of disease. That uses that is given as a tool as mobile app. So I will talk about that and invite you to some video. I'm talking a lot, so I will try to wrap it up. So we build a system where the system takes text data, image data, and video data, and we feed it to our AI system. And then this AI system analyzes the data and gives recommendation to government, NGOs, and community. And they now, in pilot areas, government is using and also the community is using our system. So what did we do? So we got small data, they have been doing this community surveillance for almost 20 years now, but they don't have data, image data. So we have been able to get 428 images of data, something like this, image like this. And then we, out of them, 228 were suspected AFP cases, and 200 were non-AFP cases. So We pre-process them, like we recite them, we removed the face part because the AI shouldn't use like people data. We remove the face part, other subordinate parts that will disturb our model to learn other things. We analyze, we removed and pre-process them, and then we augment the image, and we use a model based on transfer learning. So transfer learning is an easy principle where you have a model that has been trained on large data. Okay, you have a model that has been trained on large data. For example, here ImageNet. Do you know ImageNet? ImageNet data set. ImageNet is image of different scenarios in our world, like dog, cat, and animal, trees, and it has 1,000 classes and more than 1 million images. So models that have been trained on ImageNet were used as pre-trained models, and then we changed the output of those pre-trained models and converted into our model. So here we use Vision Transformer model. All right, Vision Transformer is a recent model that is, I think, the state-of-the-art best approach for image analysis. What we did is we took the image, the model that has been trained on ImageNet, we cut the output part and added our own layers, synchronous flattening, batch normalization, dense layer batch normalization, and output layer. Like this is a little bit like technical. Yeah, you can read the paper here, published in Infectious Disease Model Existence. So we changed the pre-existing model and customized the output and trained it on this on our image, on AFP image data set. And then we got some interesting results. Our model predicts any image for AFP, suspected and non-suspected case with area under curve of 0.87. Actually, now what we did, this is only using image. What we did is we included also text data now. And I think I got around 0.95. We have improved the output now. But yeah, this is the value that has been published. And we compared it with a model that has been trained from scratch and also state-of-the-art convolutional neural networks. So our model, which uses transfer learning based on Vision Transformer, outperformed the model that has been trained from scratch and also that has been trained using CNN. All right? So, and we also did some statistical significance, you know, like the accuracy is better, but we did statistical significance measure, and our model is outperforming those two models with statistical significance of p-value of less than 0.001. But the most important thing is like computational cost. When we talk about deep learning models, computational cost is very important. So what we did is we tested our model to see, is it effective, is it worth it? So one of the means that we use is inference time. When you give image, in how long does it give response, your model? So inference time is 19 milliseconds, which is pretty fast. But when we do it with CNN, it is around 30 milliseconds and 36 milliseconds. So inference time is better, but you achieve that inference time with an expense of large parameters. For example, the model that we used has like 87 million parameters to train with a 56 gigaflops of training. That means how many, like in how long you do like floating average calculations. How fast you do floating average calculation? 56 gigabytes. But those with less inference time, they are spending around, you know, like 36 million parameters, and you are achieving that with 6 gigaflops. So our model is a little bit expensive when it comes to like computational cost, but it is giving more accurate and fast inference time. So for us, this cost is manageable, because what we want is when we give that model in terms of mobile app, we want that mobile app to give them fast result. That is our objective. So it is acceptable for us. So challenges. For example, the data sets that have been collected, some of the data sets are not usable for our training. If you see this, can you identify any AFP even with your, your own eye? It is really difficult because one, the limbs, the limbs are the areas of paralysis, right? We cannot identify the way they took pictures, the way they collect the data. And in some cases, the quality of the pictures are also low. So this is one of the challenges that we face during the training. If we can improve this, we can improve our accuracy and our performance of our model. Ethical consideration, we do consent of the family, parents, because they are children. We ask for the consent of parents to get videos and images and data. And we do immense pre-processing. So you get the image like this. You cannot give this for AI. You have to edit it. So what we did is, we try to remove the face and sexual organs, right? We remove those. And the people around the children, we try to remove those cases. So that's how we train our model. So I will invite you to watch this video, and I will also take praise while doing so. How the model we develop, we put it into an app that the community is using. So it is how it works.
Hello.
Yes.
In this video, I will explain how healthcare officers can use polio antenna mobile app, an AI-powered mobile application used for surveillance and diagnosis of poliovirus in Ethiopian context. So in order to use this mobile application, we need to have an application installed on our mobile app. Then, as you can see, I have already installed my mobile application on this phone. So we need to click on the app. So when we click on the app, we get this interface. So as you see, the application welcomes you. So you can see the message, polio data collector, and the diagnosis app. So the main role of this application is to collect real-time polio data, as well as give an AI-powered prediction about whether the kid is polio or not. So we can use 3 different languages in order to access this app. So on the top right corner, you see the globe icon. So on that, if you click on that icon, you can see English, Amharic, as well as Afano. So I will be using English this time, so I will click on English. Then the first step in using this app is the healthcare officer has to be registered by administrator of this polio antenna project. So unregistered user cannot register directly, so cannot use the app. So in order to make the app more secure, we need to pass through this admin registration system. So I am already registered as a healthcare officer, so I will sign in by putting my phone number as well as my password. So I will put my phone number first. Then I will put my password. Then I will click on login. So once you sign into the application, you will see different information in the front page or in the home page. So you can have information about our project, or you can get information about polio antenna mobile app, about polio virus. So if you need to explore more about this topic, you can click on learn more to see what is inside these details. So now I am going to register a new patient. So in order to do that, you need to click on the 3 horizontal bar on the top left corner. So when you click on that, bars, you see this page. So in this page, my name is already displayed. My name is Mudesa. So my role is health officer in my facility. So under this, I can have access to voluntary message. So there will be volunteers under my responsibility that send us any polio suspect data, and also there's profile page where I can simply see my profile data. And also there's a create new patient icon as well as incomplete patient records, and finally there is logout button here. So when I want to create a new patient, I have to click on create new patient. So when you click on create new patient, you will get a page that gives you an access to filling patient demographic. So the latitude and the longitude is an automatic data detected by your phone, so you don't need to fill about this information. So I will start filling the information about my patient, starting from his first name. So I will put the name of my patient as first name, for example, Jury.
This you won't have
Then last name,
like previously I said, the data that is collected is incomplete, right? So we don't have that.
then
Because it won't say
phone number of
the
the parent.
get that those
So I need to fill out the phone number, then I have to select the gender of the baby. So male or female.
intersectional data is very important, right? Side activity.
Then
Previously they don't have
birth date of
just
the
see
baby.
the surveillance data.
You can
Just like high level information
by selecting the dates or the format provided by the app. So let me put this date. Then I have to select the region, when the region of the baby. So this time I will put Oromia region, then select zone, Juma zone, then Warada, from which Warada the
Where is
came,
street name for Ethiopia context.
then next. So once you finish the demographic information page, you will be redirected to clinical history form. So in this clinical history form, you have to fill starting from the date after onset. So I have to select the date after onset. Now let me put August, still one. Okay. Then fever onset, yes or no. It depends on the status of the patient. Yes, flaccid and sudden paralysis. For example, yes. RS protest, rhythm recovery. Day, yes. Asymmetry, no. Site of paralysis is not in the right leg. If it's on four extremities, you have to fill all. But for example, it could be only on left leg. So if it's only one, we can fill it accordingly. Then total OPV doses, the number of oral vaccine given to the baby before arrival. So for example, one. Admitted to hospital, yes. Date of admission, for example, date December 10, okay. Then I have to fill the medical record number of the patient, for example, SK 123, and the facility name, Salka Hospital. Then I have to click on submit. Then
This is the follow-up
I have to
Send
fill out the follow-up investigation form again,
follow-up.
the date of follow-up examination,
Is it really the virus or not?
January 25, okay. Individual paralysis, left arm, yes. Lost to follow up, if the patient was lost to follow up, you have to take this one, but this time I will keep that one, then submit. Now, this page actually is information about meteorological information about the area, so we don't need to fill this information. It will be filled by self. Then I will click OK button.
Here is
Now
after we select clinical
I have
information,
capture
image of the
so it's
suspect.
warning me. I have to put the picture, my mobile correctly on the analysis site by as much as possible by hiding the patient face, and also need to get a consent at this point. So I'm going to use sample image from my computer for this demonstration. Then I will click OK. So my camera will be open to capture the image. So I will put my camera on my patient, then I will take the picture. Then once I take the picture, I have to click next. Then after the picture, I have to record a short video. So this short video actually is for 10 seconds. I don't need to interrupt. I just start. I just click start recording. Then after 10 seconds, the app by itself stop recording and then to ask you to upload. So now I will start recording by hitting start. Then once it finalizes the 10-second duration,
every surveillance information that we need, just upload.
So
When it's uploaded, it goes every
for some time.
national level, WHO, everyone is those information. At the same
Now,
time, we
the page will be
we
redirected.
send to like the school, school has to take a
So
school of the
the
patient
patient
has
has
to
to
fill
fill
up.
out the data
It should be the
to
same
connect
to
it.
national laboratory. But there is 2 weeks
for
most of the time because we come from
So,
places and
date
go to one laboratory.
was
So to avoid that, you have to fill all those information and attach in form of QR to the stool sample. So we have to generate
this in journal. Okay.
monitoring.
Then it the second to was connected again 17 January. Okay. And then submit. Get set to lab. When the date of submission, I have to fill the date of submission. Now the file sample was collected on January 50, so let me say it will also resubmit on January 50. Okay. Sample 2, 17 January. Okay. Then I will click submit. Now I will give this QR code. So this QR code has to be saved as an image in the gallery, because when we move the sample to laboratory, the person who is bringing the sample to laboratory will bring this QR code. Then the laboratories will scan this code to get all information of the patient registered in this process. Then I click
How is the model?
the color. Now they
You
will
show
set.
the model.
Now at this point, I will show
You've collected all the
prediction
information.
reader.
The AI system will
So
give
the
you
app will
results.
to collect that as well as give its own prediction whether the result is poliovirus or not. So I will click on view model result.
So as
So as you can
the
see,
case is suspected
prediction
and it is predicting 69% confidence.
the case is polio. That is the final confirmation will be through laboratory investigation. So this mobile application is giving the prediction.
Yes. So like I want to just to give you example of like how we do it like with the community and also the how we automated integrating with AI systems. So now this year what we start is translating this experience to zoonotic disease. So One Health, animal, human, and environment. So in Ethiopia, to give you some statistics, some like brucellosis, rabies, and anthrax, these are animal diseases, are priority zoonosis diseases in Ethiopia, and also malaria. You know, in 10 months, we got 7.3 million cases in Ethiopia last year, in 2020. And it's an issue. And also there is a cholera outbreak recently, more than 30,000 incidents last year. So these are also concerned in Ethiopia. And in terms of environment, we are known with coffee production, right? Is there anyone who tastes Ethiopian coffee? Yeah. So the coffee processing has husks, you know, those coffee husks that you have to remove it, but it will pile up, right? You don't have space. What should you do? You would burn it, and you will burn it to open space. And when you burn it, that is one of the major causes for like asthma, asthma disease. So people around that the coffee has burning areas, they get those diseases, but no one is looking into that. If community is being aware and such technology is used, I think change will come soon on those areas also. The same for mining, manufacturing, waste disposal, hunting, illegal hunting, and illegal agriculture. We can go with this into those sectors. And TB, HIV, Mpox, we started working on measles. So we want to move into those areas this year. So this is measles. We have plenty of data to work on that now. So you can easily use the same process to do surveillance of measles as fast as possible within the community. Cholera, maternal and child health, like registering cases, and Mpox and malaria, we can implement the same. That is our One Health, One Health approach that we designed and that we received funding to work on this year. And then from animal disease, rabies, anthrax, and brucellosis, we are planning. We have started working on them, and this is the coffee husk. It's going to be piled up like this, and they burn it. And waste, the illegal burning of waste. You know, like 2 years ago, 170 people died. People just fall down on the people who are burning, who were burning. And illegal cutting trees and mining, which affect the environment. We can apply the same system that I showed you earlier to do community-based surveillance of these cases and making them to have a good and reliable information to change policy, to change approach, to change system, and to make people accountable for what they are doing. So here is our approach. So we have community-based One Health approach, where we look into human health, animal health, and environment, and artificial intelligence at the same time. So when we do this, we decolonization, community, and intersectionality. Decolonization, we need to have improved national capacity. You know, we are talking about South countries. We need to reach expertise, enabling local researchers like me, you know, enabling people like me, making more students interested in this and do research, solve such problems, unique knowledge creation, you know, there is unconventional data. No one used, if you search on internet or anywhere, no one used image to do AFP surveillance, right? So we are creating unconventional data, and communities should be at the same time. They should be owners. Unless they are owners, they cannot give you data. You cannot also implement the fancy idea that you bring. And the users should be the communities, not the health workers, not the health facilities, not the government. And intersectionality, segregation of data, and empowering the population is important. And as an input, we have those, and what we are envisioning is we are trying to see improved surveillance, data dashboards, and portals, mobile apps, web apps, and other stuff. So this is like our one health approach for community-based surveillance of diseases. So what are the prospects? So like we did this, what are we envisioning? Does it really matter? Does it really make sense? Did it make sense to you guys? My presentation? Did something cross your mind? What can be achieved with this? Is it? So we are changing this, by the way. So polio data, keep it like this in our country, all right? And this can be, I found this data in Ethiopian Public Health Institute, the biggest institute in the country for those outbreaks and diseases, public health diseases. They still have this data. The only online system that they use is ODK. I talked about ODK earlier, right? So on ODK, people just insert information. Like, the surveillance officer will insert information. There is no analysis. There is no prediction. There is no early warning. There is nothing. Just like Excel data that I can send you. That is what they are doing. So I'm trying to change this in the country, not only in Ethiopia, within the global south. So I think this is the prospects that we should take out of this. And I hope you guys will join me on this journey. Thank you. Any question? I'm sorry I took long time to talk, but I'm super excited. So I like talking about this area.
Interesting. So any questions from the online audience or people in person? Shankar, in fact, you really presented a great framework because in terms of emerging infectious diseases, especially emerging, not like the regular
already
disease.
Yes.
But the CBS approach, community-based, because this is really the fundamental places where the possible pandemic or epidemic will appear. So of course, this is like the work, as I see it, is presented for SOPIA.
Yes.
So the program and the data and the research with the purpose for. So if you go back, I see you listed a long list of zoonotic diseases in that table.
Here?
Yeah. Of course, this too. The last page you see.
Yes.
This is like long list.
Long list, yes.
The zoonotic diseases in Ethiopia.
Yes. This Ethiopia is with I don't know what you mean this color brown. Yeah. So these are the diseases like in Ethiopia, is their frequency, their case number, right?
Okay, you use color to
Yes.
not exactly.
Like, these are from Africa, Burundi, Ethiopia, Kenya, Rwanda, Tanzania, Uganda.
Yeah.
Those are the diseases. For Ethiopia, these are the cases. So totally within these 5 countries, trypanosomiasis is like the highest one. But for each country, that is the number of them. But as a policy of the country.
In fact, for now, brucellosis.
Yes.
It seems like, is this the top second?
Yes. In Ethiopia, for example, this is like the number 1 case that they take as a priority. Those animals that are affected with this, if people eat them, it's like a big emergency.
This is indeed.
Yes.
Yeah. This framework, of course, because this historically also, even the data proved this is there.
there. Yes.
So basically, through the system you are developing, in fact, it will improving. It will improve
Yeah.
greatly, you know,
Most of the time. Yes.
the system.
Yeah, but those effects like pandemic and other issues, they are affecting because people are losing.
But you know, the only what I hear most is like, of course, currently there's so many different type of losses, and then you know for the CBS, the community-based surveillance. So the purpose of the CBS is to
Engage the community to that because the health system is
engage the community
yes, for disease surveillance. Informing-
for prevention,
yes, for
to
informing.
reduce the health burden, and because you know it's anyways endemic.
Yes. The thing is, for us, what we are using the community is to get the disease as early as possible when it happens. For example,
Early detection.
yes, early detection.
Early detection
Yes.
in fact, like to reduce
To
the
reduce
total
the
number of infections,
fatality.
reduce deaths,
Yes,
reduce the health burden.
yes.
So this is the
That's
purpose.
the purpose. And we are empowering them to improve that using those digital technologies and AI. That's what we are.
This is, of course, this is important. This is the problem. That's basically in order to do this. The other problem is resources.
Yes.
If the government, you want to do this, if the whole government structure,
Is
they will give you resources
resources.
to do it.
So what we are doing is now, like we have 9 regions, like in Canada, we have regions, right? Ontario.
Yeah.
something like that. So we have one of the biggest regions now. They are working with us. We started working with them on
No,
malaria.
I do not mean that. The problem is like if, for example, Ethiopia or Burundi or Kenya, the government is willing to, even though you have this system built,
Yeah.
but in practice, if the government does not chip in money
Yes.
to improve the health system,
It doesn't.
even though you have this AI, whatever tools available, you need the government or financial support
Absolutely.
and the government administration to allow you
Implement it, right?
to implement
Yes.
the so-called much better AI
System.
system. Yeah, it's great. Like you know, this is really important.
But most of them are not doing that. That is irony. I am more of interested in the image aspect of the stuff because no one is working on the image aspect. For example, in global
Look, here, in fact, like in Antioch, we have a few people. One is in our department, the other is in computer science. They are doing imaging data, type of data
okay.
for their study.
Okay.
In fact, even our OMNI, we have OMNI is doing the imaging processing.
For global health stuff.
But that is for MR. What is that?
MRI. So yeah, that's what I did for my PhD. I work on mammogram, ultrasound,
Medical image.
histopathological image, you know. Like, but no one is looking into the global health aspect, you know, like the daily.
No, this is different type of image.
Yes, that's what I'm saying. So that is where I want to tap into. Because
Yeah, it's
very
different
interesting.
skill,
Yes.
or it's different.
I think that's why I learned this.
Let's see who is online. Any problems from online? Maybe it's over time. People are quitting. Also, if questions in the chat.
Fantastic presentation, but still good. Yeah, I have one more question. For surveillance officers, I'm thinking about how many of them are needed for each district, and in case they are reporting for polio, as mentioned, are they at the same time reporting other diseases, or as you mentioned, crime is really important in this law.
So in Ethiopia, there is something called PHEM, Public Health Emergency Managers. So they are the ones who report those things. So for example, in Ethiopian context, we have something called Warada. I told you earlier, it is a district. So for one district, you have one favorite. So he looks into every public health emergency disease. So whether it is polio, whether it is other measles, mpox, they look into the generalized every disease, and they report. So and they have to visit. For example, their schedule is once a month, right? Once a month, they round all the health facility within their district, and they look for cases if there are cases that have been reported. That's how yeah, per maybe, for example, we have health centers in one district. They minimum 30 health centers are there. So one officer is for 30 health centers. He has to visit once a month and do that surveillance. So that's why it's late also. Like if he came a month ago, during this time, if something happened, he will miss until the next month.
30 days.
Yes.
Thanks.
That's how they. But for us, we are doing it instantly. You get the case now, even WHO has it. Just today. That's what we are. Any other question?
How long have you been working on this PS space?
2 years.
2 years.
Yes. 2 years.
It is a lot of work.
Yes.
So in career, so the career opportunity help give you the support to do this related study. Because you were in Korea for your PhD
In Korea,
in Korea.
yeah, what I did is breast cancer.
Okay.
So, yeah, so I learned those image computer vision there and AI, but I thought, those results are fancy for me. Like we are doing fancy stuff. I didn't even get Ethiopian data, for example, for breast cancer. So I thought I should go into where I can be impactful, like where my education gives more impact. That is when I joined, this public health stuff. And working on this.
Of course, I believe this is very promising.
Yeah.
Also, you need a lot of really effort because now you are in Canada, but how to further develop this technique and make it implemented in opium. That is more challenging.
Yes, absolutely. But like AI for PEP, being under AI for PEP helps a lot. We are working with like 16 countries in the global south.
Okay.
So yeah, like we are creating a little bit of like synergy where we collaborate, and also having this opportunity at CDM is also, I think it will help.
Yeah, in fact, we are talking about in next month or in March. There's a guy, the director of scientific director of the AIMS, American Africa Institute of Mathematics.
Society, something like that.
Yeah. In fact, that guy is coming to discuss the collaboration of STEM with them. We signed agreement with them, but not really did anything, contribute anything to South Africa.
Yeah.
Great sauce. Any questions? If not, let's thank
Yes.
Dr. Ayana for his very interesting, informative talk. Thank you.
Thank you.
Thank you everyone for joining us. Have a great one.
Yeah, let's have a brief. This is in fact next. We are working on to apply that